So my work is rooted in disability rights and disability justice, but in my presentation I do use some language from other social justice movements out of appreciation and not appropriation. So the Americans with Disability Act has been civil rights law in the United States since 1990 and has fundamentally reshaped disability access and inclusion in the United States. Yet people with disabilities remain an unrecognized health disparities population who face unequal access to preventative, primary, and specialty care, while also being disproportionately impacted by the negative consequences of social determinants of health. Furthermore, only 1 in 4 people with disabilities has a usual source of care, forcing people to rely on emergency departments, delay needed services, and enter the healthcare system sicker with more complex and costly comorbidities than their non-disabled peers. These inequities are not accidental. They are the result of physical, financial, and attitudinal barriers embedded in the healthcare system. And now, proposed cuts to Medicaid further threaten the health, independence, and survival of the 70 million Americans with disabilities. Framed as fiscal responsibilities, these policies instead reveal deeply embedded ableism and reinforce harmful assumptions about whose lives matter. Disabilities communities are experiencing both fear and mobilization, as well as a heightened sense of urgency for collective action and advocacy. For nearly 2 decades, my work has centered on partnerships with disability communities to advance healthcare justice through community-driven solutions at the individual and the policy level. Using community-based participatory research, our interdisciplinary team of disability rights advocates and scholars has developed the Access Equity Model. This is grounded in aggregated qualitative data from numerous cross-disability samples, and the model identifies modifiable barriers and supports at both the individual and environmental levels. It also aligns with the World Health Organization's ICF framework to highlight measurable outcomes. But critically, the model moves beyond deficit narratives that center community strengths, such as experiential knowledge, resilience, and hard-won self-efficacy and patient activation, while also providing multiple entry points for intervention and action. So we have applied this model through several iterations of peer support and self-management interventions, such as the Our Peers Empowerment and Navigational Support, peer navigation studies. We have created in partnership with disability organizations and grassroots community members. Our team of navigator scientists serve as both research developers and interventionists to ensure that the intervention is relevant and responsive to the needs of the communities we serve, such as people with acquired disabilities. Our interdisciplinary team is also creating custom technologies to enhance accountability, information sharing, social connection, communication access, and treatment fidelity. Through meaningful collaboration with diverse members of the disability community, we are helping to bend the arc of history towards healthcare justice for people with disabilities.